Hello, everyone. I'm Dr. Carmen Pugliafito, and I'm here today with Dr. Stephen Yeh, who is the Trulson Chair at the Trulson Eye Institute at the University of Nebraska Medical Center in Omaha. Steve, welcome to Retina Synthesis.
Carmen, it's great to be here with you on Retina Synthesis today to talk to you about suprachoroidal drug delivery.
Well, you've done pioneering work in the area of suprachoroidal drug delivery with microinjection. And can you tell me how this all started?
Sure, Carmen. First of all, again, thank you so much for the opportunity to be with you on Retina Synthesis today to really inform the retina community about all the advances going on in the field. And so I became involved with suprachoroidal drug delivery as a result of a collaboration that was already ongoing between Emory and Georgia Tech with Hank Edelhauser, Mark Prausnitz, and Samir Patel, who had really invented and started to develop and advance and pioneer the microneedle. And they were interested into its potential impact for use in uveitis and retinal disease. And the company Clearside Biomedical was shortly developed thereafter to look at suprachoroidal drug delivery for the treatment of uveitis and other retinal disease indications. And I became involved from the standpoint of understanding the microneedle, learning about the technology, assisting with the design principles, and ultimately helping to design some of the early phase trials, moving from the phase 1 to ultimately the phase 3 pivotal trial that looked at Xipere, at the time suprachoroidal CLSTA, for the treatment of macular edema due to non-infectious uveitis. And so I was really fortunate to be in the right place at the right time with really outstanding collaborators from different institutions. Again, and this is something that I know that you can speak to, is really the intersect between engineering, design, and medicine.
So can you tell us a little bit about how the direction that was taken to try Triamcinolone and macular edema and uveitis is the first clinical application?
Sure, absolutely. Well, we know that corticosteroids are very broadly acting. We know that they are excellent at because of their anti-inflammatory properties, as well as their effect on vasopermeability. And because of that, that was what the route that was taken to instill this medication within the suprachoroidal space, with the concept being that you wanted to increase the amount of drug in a very compartmentalized fashion, increasing the levels of drug to the retina and the choroid while limiting the amount of medication to the anterior segment. And with the concept being that if you limited the amount of medication to the anterior segment, you could potentially reduce the complications, i.e. elevated intraocular pressure, cataract, while potentially increasing your efficacy signal. And that's really what drove that application of this technology for uveitis, looking at the reduction of macular edema and improvement of visual acuity by having more medication within the target tissues.
Can you tell us a little bit about the Peachtree trial, which is the pivotal phase 3 trial?
Sure, absolutely. So the Peachtree study, as you mentioned, is the pivotal trial looking at the suprachoroidal CLSTA, the corticosteroid triamcinolone acetonide, which was a proprietary formulation for macular edema due to non-infectious uveitis. And the way that the trial was designed is that patients were randomized to either the suprachoroidal corticosteroid or to the sham group, and patients were allowed to receive rescue injections through the 24 weeks of the trial. The primary efficacy outcome was visual acuity, and other outcomes that were important included central subfield thickness as measured by OCT, and also looking at adverse events. And what the Peachtree study found was that patients who received the suprachoroidal corticosteroid injection, or now known as Xipere, 40% of these individuals achieved a 3-line or greater improvement in best corrected visual acuity compared to 16% of individuals in the sham control arm, which was really impressive from a visual acuity endpoint perspective. And this was really reflected in the reduction of macular edema by OCT measures, with patients receiving the medication showing a significant reduction in macular edema of approximately 150 microns. We saw these results at the week 4 time point, and at week 24, you continue to see this sustained response in the anatomic improvements.
So how long is this really a sustained delivery approach?
So that's a really good question. So the kinetics of the medication, I think in patients that haven't been measured in patients per se, but what we do know are really from the Magnolia trial, which is the extension, which is an open label extension trial. So patients who went through the Peachtree investigation were followed if they did not have rescue therapy at the end of the Peachtree trial. And we found that 50% of these individuals who were 50% of the individuals who were treated with the medication, the suprachoroidal corticosteroid, about half these patients did not require additional rescue medications at the week 48 time point. So this was fully 9 months out after their second suprachoroidal corticosteroid injection. So at least the top line result from Magnolia is that 50% of individuals who received the suprachoroidal injection did not need additional rescue therapy. And so that gives us some sense of what durability may look like. And this is something that continues to be investigated.
There are lots of options available for uveitis clinicians in terms of steroids. Why is Xipere something that has some advantages?
Yeah, so one of the aspects about Peachtree is really related to the inclusion criteria, that patients could have inflammation involving the anterior segment or anterior uveitis and all the way back to the back of the eye, posterior uveitis, intermediate uveitis, and panuveitis. And so the inclusion criteria were quite broad. Patients were also allowed to have IOP lowering medications of up to 2 IOP lowering medications as their inclusion criteria. And really I think that one of the aspects of the medication that is really compelling is the highly compartmentalized aspect of the medication. Again, that there's high levels of drug within the retina and the choroid and lower levels of medication within the anterior segment, with the potential for improved efficacy with reduced concerns about safety signals. And these are some of the more compelling reasons I feel that this is a medication that's to be considered for macular edema due to non-infectious uveitis.
So intravitreal drug delivery has a higher rate of anterior segment complications than suprachoroidal delivery.
So currently there's no head-to-head comparison between intravitreal versus suprachoroidal drug delivery. Again, the comparator arm was the sham control arm. There is some post hoc analysis that suggests that patients who receive suprachoroidal corticosteroid versus sort of real-world therapies compare favorably from the standpoint of visual acuity, as well as safety outcomes. But I think that story is something that needs further investigation. But there's currently no head-to-head related to intravitreal, the current medications currently on the market versus the suprachoroidal drug delivery technique.
But the incidence of increased intraocular pressure was low.
That's correct. Yeah, within the suprachoroidal drug delivery arm, it was about just over 11%, and it was about 16% in the individuals who were in the sham control arm, acknowledging that patients who were in the sham control arm could also have rescue therapy. The majority of situations were, again, real-world corticosteroids that were given at the discretion of the investigator.
So what about initial case selection? When this drug is available, what recommendations do you have to your colleagues in the uveitis community about case selection and use?
Yeah, so again, kind of going back to the inclusion criteria, we have sort of a broad population of patients, anterior, intermediate, posterior, and panuveitis, who would be eligible for this type of this medication, and also having macular edema associated with non-infectious uveitis. I think that there's certain situations if a patient is on IOP lowering medications, they can have up to 2, and they could be considered for this medication. Some patients are interested in a different option, and because it is a novel and innovative option and really an alternative to other medications, I think these are patients where I think that would be considered for this medication, acknowledging again the efficacy and safety signals from the phase 3 study data.
So what about eyes with, so it's both anterior and posterior segment uveitis
That's correct.
Are eligible.
Right, that's correct.
Can you give us some anecdotes from your cases that you've treated?
Sure. So I remember distinctly there was one gentleman who's was in his 40s, history of sarcoidosis and really severe macular edema around 20/80 visual acuity. And essentially he had other intravitreal corticosteroids as well as periocular corticosteroids and was just really interested in a different option. And so he elected to be in one of the I believe he was in the phase 2 trial, and he did very well. He improved from 2080 to 2032 at the month 2 time point, with a substantial reduction in macular edema. And this effect was seen even later on as we continue to follow this individual. And there are other individuals who I've seen who have this durability signal. And I think that the Magnolia study, which again sort of speaks to the durability question, it really is about 50% who end up not needing rescue therapy at the month 9 time point. And so there's other individuals sort of in this category, other individuals I've treated with intermediate uveitis who have also done well with suprachoroidal drug delivery.
So can you discuss your surgical technique?
Yeah, so that's a great question. It is a different technique than the intravitreal drug delivery technique, but given that there are over 50 centers, multiple investigators in 3 countries, including India, Israel, and the United States, all of these investigators learned this technique. And my specific technique, I want to make sure the patient's comfortable. And so I like to use subconjunctival lidocaine. I counsel the patient if they've had intravitreal corticosteroids that they may feel a slight pressure during the procedure. And then when I use the microneedle, it's important that the needle is perpendicular to the surface of the eye. I displace the conjunctiva from a safety perspective, and I ensure that the microneedle is perpendicular to the ocular surface. I make a very small dimple, and I slowly depress the plunger. And as I depress the plunger, I feel a sense of there's a loss of resistance as the medication goes into the suprachoroidal space, with the principle being that the resistance is much higher within the sclera than in the suprachoroidal space. And so once you feel that loss of resistance, then the medication goes in very readily when you depress the plunger, and you're not going to see egress of any corticosteroid within the ocular surface. And so it's less pushing and more of a finesse movement. Again, it is nuanced, but again, it's something that I do think that can be learned by any individual who gives intravitreal corticosteroids and treats this population of patients.
What quadrant do you make the injection in?
Yeah, so I personally go in the infratemporal quadrant. Other investigators will go in the supratemporal quadrant. I think it just varies from. I think it has to do with, as you know, Carmen, it really depends on the field, the ergonomics for each individual in terms of which quadrant their preferences. And if there's any concerns about scleral thinning, then I don't go in that quadrant. Some of our patients who have had corticosteroids before, we have to monitor for that, and that's the only caveat that I would say.
Is there a choice? Is there more than one needle?
Yeah, so there's 2 needles. There's a 900 micron needle and an 1100 micron needle. And the 900 micron needle was found that was effective in about just over 70% of individuals. And for other individuals who needed 1100 micron needle, then the other population would fit in that 1100 micron category as well. But I typically will start with the 900 micron needle first.
Well, this is exciting. What are your comments about the use of suprachoroidal injection for gene therapy and for angiogenesis therapy? Some comments about that?
Yeah, I would just say that there, as you're aware, and I think that there's other investigators who you've spoken with on retina synthesis, and this is just a really exciting time when we think about drug delivery. And there's a number of studies that are underway, and I'm excited about the possibilities. I think that, again, the suprachoroidal space is just such a unique location for drug delivery. And as you mentioned, there's gene therapy, there's work ongoing related to tumors. And other therapies as well, thinking about macular degeneration. And ultimately, I think that the trial data will speak for themselves, and I won't speak to the specifics of the trial data. But I do think that as this technique was FDA approved for the first indication in uveitis, I really think that's exciting for the field and how we think about future drug delivery techniques and other therapeutics for other disease indications, as you've mentioned.
Well, Stephen, it was great having you on Retina Synthesis, and we look forward to introduction of this powerful new tool.
Carmen, thanks so much again for the time to spend with you and for all of your and Charlie's work on Retina Synthesis. It's great to chat with you today.